Good afternoon. We are just going to let everybody get into the room today. Welcome, everyone. Just give a minute here, and then I will start with some of our housekeeping slides. All right. So, good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Welcome to today's program. As you connected, some webinar tips and notes, your phone or your computer microphone were muted. We will be utilizing the chat function for any Q&A, any questions you have. Please go ahead and type them into the chat. We'll keep an eye on that for those questions. We also have a post-webinar evaluation that will show up in a pop-up window behind the scenes here. And please go ahead and fill that out. For those of you seeking the CME credits, there's a code that you will be able to log in and text in actually from your phone. The numbers included. If you don't have a Cloud CME account with us, with the University of Arizona's Continuing Medical Education, I'll have that information in a thank you email that I will send to you, and you can get that set up. We utilize that portal, the Cloud CME portal, for all of our CME webinars, and you'll be able to print a transcript for today's session and future sessions. This will also be recorded and be available on our website. You don't need to worry about writing down that URL because I will have that in my thank you email as well. So here's today's continuing medical education objectives, the accreditation statement, the relevant financial relationship statement, and again, my attendance tracking for the CMEs. If you haven't set up your profile, I will get that information to you. It'll be in that thank you email, or you can reach out directly to me after the program. This is a standard disclaimer. Opinions expressed in the presentation on the following slides are solely those of the presenters, not necessarily those of the organizations sponsoring the webinar. Organizations do not guarantee accuracy or reliability of the information provided. And again, be sure to check our website for upcoming webinars and events. We've got a couple more webinars yet to this month, and we're working on our 2026 schedule. So be sure to check our website for upcoming and future events. And again, your opinion is valuable to us. Please go ahead and fill out that evaluation. We enjoy getting all of those comments, and we use those comments to help come up with new topics to bring to you, our audience. This webinar is also made possible through funding provided by the Health Resources and Service Administration's the Office of Advancement of Telehealth. So today we have a webinar on telenephrology, keeping care local via telenephrology. And we have two representatives today with Teleneph. We have Rhonda Mason. She's a Chief Nursing Officer and Chief Operating Officer. And then we have Mandeep Sahani. And he is in the process of getting logged in. Of course, we know how busy physicians can be. So I'm going to go ahead and stop sharing. And Rhonda's going to go ahead and get her slides up. And as soon as he connects, we will get him added in here. We're going to go ahead and have Rhonda get started. And Rhonda, if you're ready, you can take it away.
Great, I am ready. Thank you so much. Appreciate the invitation. My apologies, Dr. Sahani is logging on, and so he should be here momentarily. But as Melanie said, I'm Rhonda Mason. I'm the COO, CNO of Teleneph. Excited to talk to you about telenephrology. We are located, our offices are in Denver, but Dr. Sahani and I are actually located here in Arizona. I started a telenephrology program in Globe, Arizona about 7 years ago as the CNO. And it is such a phenomenal addition to the services that they provide. And sorry, Dr. Sahani is trying to reach me to get logged on here. I apologize.
Do we need to send another link to him?
Melanie, can you send him a link? Do you have his Desert Kidney email?
I don't think I do. Hold on just a second here.
I am so sorry.
That's okay. That's
everyone
right.
on.
We will get that sent over to him. Hold on just a second, please.
I think I just, sent it his way. So let me make sure he's got it. So again, we started about 7 years ago, and Dr. Sahani is the CMO, and he practices at Desert Kidney there in Arizona, and also provides teleservices with us. So I'm going to give him just a minute, and I again am
That's all right. We will.
very apologetic. I just told Melanie he's always incredibly prompt. So
Except for the one
there,
day when you were expecting it, right?
that's right. There must be something going on. Um, anyway, I'll give
All
him just a
right.
second, see if he can get on there.
Ref, can you pull the login link for him? I'm working on getting logged into that. I'm afraid it might kick me out though if I change accounts.
And
And Ron, if you have a different email address, oh, let's see here. Laura. Thank you, Laura.
oh, Laura, did Laura forward it on?
Yes, hold on just a second. Ref, I'm going to send this to you.
Thank you, Laura. She always comes to our rescue. There he is.
All right.
Hi, Dr. Sahani.
Hi, guys.
Welcome. All right, I'm going to go ahead and pass the mic over to you folks. Thank you again.
Thank you.
Okay. Dr. Sahani, I have the slides, and so I just did introduction, and I will forward it on here. Oh, now my slides aren't forwarding. I tell you, technology today is going to be, oh, there we go. Okay. Do you want to give just a little intro, Dr. Sahani?
Absolutely. Thanks, Rhonda, and thank you for having us at the Arizona Telemedicine program. My name's Mandeep Sahani. I'm a practicing nephrologist here in Arizona now for 21 years. Rhonda and I partnered back in 2019. The idea was to fill gaps in access to renal care, access to nephrology care in rural communities. Our first pilot, as you will learn quite shortly, was at the Cobra Valley Hospital in Maglow, where we started our first inpatient telenephrology program. Thanks, Rhonda.
Thank you. Just a little background about nephrology needs in the U.S. So chronic kidney disease, about 14% of the population have it. 2% of those patients are ESRD. I think what anyone who practices in nephrology knows that these are high utilizers of healthcare. And so in the rural market, specifically where we spend our time, they go elsewhere for most of their services if they cannot get their nephrology needs met at the local hospital. And that's really kind of where Teleneph started. These are the top reasons, diagnosis why patients with ESRD and CKD come to hospitals. And it isn't related to specifically to their dialysis need, but if the facilities can't provide dialysis treatments and don't have nephrology consult, patients are turned away. And certainly at Cobra Valley, we saw this that the minute there was any mention of ESRD or CKD when a patient was in the ED, the process started to transfer the patients out of the community. And that has such a significant impact, not only on that patient, but their family, and then the hospital as well. And so Teleneph's focus is rural. And here's some statistics about rural and really the devastation that shutting down hospitals and healthcare in rural communities, what an impact it has on those communities themselves. And interestingly, that in 2023 reported a 13% increase in telemedicine. And I think we'll demonstrate for you today that telemedicine is just ideal for nephrology. And Dr. Sahani certainly lives that every day. These are the numbers in by county in Arizona of CKD and ESRD patients. So you can see where those volumes are. And the different counties. For example, Gila County is where Cobra Valley is. There were 126 ESRD patients in that community. CKD 6,300. And it's always interesting to note that the majority of patients with CKD, or at least a good percentage, don't know that they have CKD. And so again, having nephrology services available to them when they access healthcare in any area is of such great value. So Dr. Sahani, I'm going to let you talk a little bit about keeping care local and how Teleneph became.
Fantastic. Thanks so much, Rhonda. It's a story I'd love to say it again and again. It started by the CEO of the hospital over Cobra Valley, Neil Jensen. It was quite frankly his brainchild. Persistently, he wanted to close the gap when our community patients over at Globe and the surrounding areas who are on dialysis, if they can receive dialysis in the community, why can't they receive dialysis once they come to the hospital, even if it's for a low acuity condition, like if they've had a pneumonia or cellulitis. That drove that idea, and that need to close that gap drove the birth of Teleneph. Rhonda came on board at that hospital as a chief nursing officer, and she had this great idea that if patients can be trained to do dialysis at home using the newer technology, using the newer sophisticated machines, then why can't we train nurses who are working in the ICU, adopt them and train them on the newer machines, and then using that training, why can't we admit these dialysis patients and take care of them while they're in the hospital? That was a thesis that drove the birth of Teleneph in Arizona. We dialyzed a few patients. We recognized that, yes, we have something here. We continue to dialyze the patients. Remember, this was back in 2019, and then 2020 happened, and then we had, of course, COVID, where this program became a blessing in disguise, not only to our community where we started this pilot program, but also the surrounding rural communities that were having difficulty in getting patients admitted to the valley, to the bigger hospitals where this service was being offered. That created a program, a template, which now provides 24/7 access to nephrology support. And that is not just dialysis nephrology support, but that's the entire gamut of what a nephrology support looks like, which is if there are problems with acute kidney injury, if there are problems with electrolyte, whether it be sodium, potassium, or just acidosis, we can cover all that by our program.
Thanks, Dr. Sahani. And really the thesis we've seen this over and over again across the country. So Teleneph serves facilities in the South. We serve facilities in Alaska, Hawaii, clear through the Midwest, and obviously in Arizona. And really, again, stopping transfers of patients, stop the drive, stop the flow of money out of the community, and letting neighbors take care of neighbors. People who live in rural America, which I so fondly have done for many, many, many years, they want to have the same quality of care and access to care in their local hospitals. And driving into Phoenix, for those of you who drive into Phoenix on a regular basis, know what a challenge that can be. And, on top of it, going to visit loved ones when you're not feeling well, all of those things are taken into consideration. So Dr. Sahani, how tele works with nephrology, it's really a great specialty for telemedicine. If you want to touch on that just a bit.
I always say that I've always believed that that nephrology was made for telemedicine, or telemedicine was made for nephrology. And by that I mean is nephrology, as you know, is an extremely data-driven specialty. At certain points, most of our patients, either they have CKD or they don't. And we make most of our decisions based upon the data that is given to us, which is simple blood tests like a BMP, CBC, or just a UA, a urine protein, and a urine creatinine. So we're the ideal specialty that can do remote practice of medicine once the data is presented to us. Most of our hospitals have the ability to get these simple blood tests, and technology vis-a-vis the televisual technology has changed so much, and the access to use and adopt has become so much easier that we can now even see our patients on a simple tablet. We don't need the heavy equipment on televisual as we had to do a few years ago. So based upon the clinical data, based upon low-tech technology, we can serve these patients, keep them in the community, get them dialyzed once we've had the adequate training of the nurses. The equipment, as you will see in the next few slides, that we perform dialysis, the change in the equipment, the ease of the equipment has made this very much easier for us as well.
It has, and here's an example of the equipment that is used in the outpatient centers. It's big, it's not very portable, complex, expensive. The learning curve is long, and it really is challenging in rural settings for the general nursing staff to learn how to use this type of equipment. And so, as Dr. Sahani said, what has changed is several vendors have come out with what they originally created for home hemo use. So these are three examples of home machines that are now being utilized in the acute settings and provide quality dialysis treatments, are incredibly easy to use. Over and over again, I tell the nursing staff of the different facilities, patients use this at home. So we, as very smart, educated nurses, certainly can learn how to use it. And we see it all over the country. Nurses take to this equipment incredibly well. The manufacturers have amazing support. And so really, probably the bigger challenge than the equipment is just working with the nurses on re-educating them on the care of nephrology patients, because often in these rural facilities, they haven't kept any patients with CKD, ESRD, AKI, certainly not. And so really giving them that basic knowledge of the care of the patients is by far probably the majority of education that's spent on that versus the equipment, because again, the equipment has become so easy to utilize. So Teleneph really has a very flexible solution. We have grown tremendously in the last many years, and we really do provide a lot of different resources depending on what the needs are at different facilities. So some of our facilities, we provide full service telenephrology for any type of nephrology need, as Dr. Sahani mentioned. The nurses of the facilities do the dialysis treatments using one of these pieces of equipment, and we support all kinds of nephrology patients coming in. And I think that's one of the things that was so surprising at Cobra Valley is we were very focused on the dialysis patient without thinking about all the volumes of patients that had nephrology needs that were not yet ESRD. And so that those CKD patients, AKI patients. Another model we have is some of our facilities, they hire out the nursing staff from some of the larger companies and have them provide the dialysis, and we provide the nephrologists for those facilities. One of the other models we have, which is called continuity of care, or it's a gap coverage. Some of our rural partners that we work with, they have a nephrologist in their community, but they only have one. And facilities do not want to burn out one nephrologist. They had hard enough time getting that nephrologist, I'm sure. And so being able to support those nephrologists, provide coverage, call coverage for them, et cetera, is a service that we have seen that need grow tremendously. And other things we can support are CKD clinics, analyzing the need for outpatient services. Again, it's just really interesting talking to rural hospitals and communities about what their needs are, and their residents are being transported or driving 60 minutes each way, an hour and a half sometimes to get their dialysis 3 times a week. And so you can imagine, the burden on the patient and their families, et cetera. Uh, we talked a little bit already about Teleneph really does impact all service lines and areas such as podiatry and orthopedics, cardiology. It isn't a silo solution. It really does significantly impact the hospital total revenue. It We have found that nurses have great satisfaction in learning a new skill set, taking care of a new group of patients that they have not historically managed, and it really does, as I mentioned, creates that halo effect. More patients come to the local hospital for services when they know that nephrology is available to them. This is some of the comments from some of our the hospitals that we work with. But really, most important, I think, of this whole conversation is Dr. Sahani has some amazing case studies that he will talk through with all of you, things that he has identified through telemedicine and been able to treat successfully. So I'm going to just hand it over to Dr. Sahani.
Thanks, Rhonda. Before I go into this particular case, that was very interesting. It was in the middle of COVID. And prior to this was, I believe, our 6th or 7th month into our first pilot program. And by then we had trained and treated quite a few dialysis patients. We had already seen some AKI patients and some CKD patients as well. Our nursing staff by then in the 6 months prior to seeing this patient were very comfortable in taking care of dialysis patients, and now we're very comfortable, mostly some by choice and some not by choice, because this was the middle of COVID, to take care of sicker patients. This young girl came to our hospital via the ED being obtunded, was profoundly acidotic with a huge anion gap. And remember, this is a small critical access hospital, 25 beds, limited resources. So we had to just use everything we had with myself, the hospitals, all hands on deck to figure out what was going on. Clearly, she had AKI, she was acidotic, so dialysis was recommended. We started dialysis right away using the next stage machine, as you saw in one of the previous slides, but we still didn't have a diagnosis. And we didn't have the ability in our lab to send out toxic alcohol levels. So we went old school. We tried to rule out what this patient could potentially have. We ruled out ethylene glycol by bringing a Woods lamp from the ED. It wasn't ethylene glycol. And by process of elimination, we found out that it was most likely methanol. As you recall, during that period of time, there was a shortage of hand sanitizers, and there were folks who were making hand sanitizers in their backyards, but not having the proper distillation. So there was a substantial ratio of methanol present, and not so much of alcohol in those hand sanitizers. And this lady was unfortunately an alcoholic who resorted to taking the hand sanitizers, and that's how she got the methanol poisoning. And then once we diagnosed this with methanol poisoning, she started doing better on dialysis, but her levels were so high that dialysis could not keep up with it. And of course, the antidote is fomepizole, which we didn't have at our small facility. So again, we went back old school. We were able to purchase and get medical grade alcohol, drop in an NG tube on this lady, and then we started treatment by giving her alcohol that competitively inhibits alcohol dehydrogenase, so methanol is excreted out. Throughout this time, there were no beds available in the inner city. We couldn't transfer this patient. About 36 hours later, when a bed became available, we transferred this patient in a more or less stable condition. And then later we followed up, and then she was discharged from that hospital with all the faculties intact. As you know, blindness could be a terrible side effect of methanol poisoning, but she kept her vision. She walked out of the hospital 100%. So this, along with a couple of other cases, gave us enough confidence that we can manage the sickest of sick patients. Of course, we do need the resources, but even with limited resources in the rural communities, given challenging times, we can manage these patients. So that was one patient that we saw. Another patient who was a truck driver, happened to pass by a small town in Globe, felt extremely weak, got admitted to the hospital. We saw that he had a very low potassium level, and then but he was a young gentleman, not on any medication that might lower his potassium. We really quickly sent out a quick set of labs. We did a TSH, it was abnormally high, and we figured out that this individual patient had hypokalemic periodic paralysis. We gave him the diagnosis. He followed up with his PCP once he got home, and then he was lucky that nothing happened while he was driving this truck. So that's another successful case. And I believe there's one more, Rhonda. Yes, the limitations we recognize that we can't do everything. We can do most of treatment for most of the diagnosis that a community sees, AKI, CKD, dialysis, but we can't do kidney biopsies. In this particular elderly gentleman, we suspected that something else was going on, not the usual causes for CKD, diabetes, and hypertension, but we didn't have access to doing a kidney biopsy. We transferred him, he had a kidney biopsy, and through that we diagnosed that he's got multiple myeloma. So these few studies and lots more since 2019 we launched the program, we've recognized that we've been able to take care of patients, some who are low acuity and some patients also of high acuity. Thank you.
Thanks, Dr. Sahani. So I think, Melanie, I know we walked through that pretty quickly. Dr. Sahani, did you have anything else, or should we open it up?
We can open up the questions,
Sure.
but I just want to say this program is only as successful as we get the confidence and the buy-in from the nurses, because these are nephrology night nurses. They are trained by skilled dialysis trained nurses, but the response time, they're always looking for how soon is their nephrologist colleague responding to them when any questions arise. I think bridging that gap and building that relationship, increasing the comfort level, decreasing the anxiety level of nurses will make any program like this very successful. So thank you.
All right, so if anybody has any questions, you can go ahead and put them in the chat. I had to step away for a moment. With regards to, setting different connections up within the rural communities, Rhonda, you mentioned that the first one that you had started with was in a rural community. Is that correct?
Correct. It was in Globe, Arizona.
In Globe, gotcha.
Mhm.
Are they still utilizing the telenephrology type of systems out there?
They are, and again, most of the communities that we talk with, recruiting a nephrologist is near impossible. And so Globe continues to utilize telenephrology. Their program has grown substantially. They actually accept patients now from other rural communities, which is kind of unusual in the critical access world. Most critical access hospitals, they have certain specialties they can manage.
Sure.
Some very low acuity. Globe happens to be a very high functioning critical access hospital, so they have a lot of specialties. But even with that being said, it isn't really common for them to have patients transfer in. More often than not, they're transferring patients out, right, that are higher acuity than
Sure.
what they can manage in the area. And so, part of, again, Dr. Sahani mentioned, probably part of some of the success of the program at Globe was COVID. We were pressed to take care of patients that we probably wouldn't have kept within that facility, but due to bed availability in the Phoenix area, we were keeping a lot of patients. They're high acuity. That certainly got the program running and the nursing staff really comfortable managing nephrology patients. and they continue to grow that program. And again, they are bringing in patients from other rural communities. People who live rural would much rather go to another rural setting
Sure.
where they can park their car walking distance from the front door. They can actually find the cafeteria when they walk into the hospital,
Right.
that smaller, quaint, but at the same time, the expectation is the same high quality care is provided wherever they get their medical needs met. So that program is continues to grow, and I know Dr. Sahani continues to support that program.
That's incredible to hear, and it's great to hear that you've got rural communities helping other rural communities as well, right there.
Absolutely.
We do have a couple questions that have popped up in the chat. Thank you for those that are putting them in. So the first one is, how many nephrologists do you have on a call rotation, and what's the average census?
I can take that first question, Rhonda.
You bet.
So we dedicate not more than 2 nephrologists to every hospital. And that's important because that builds a relationship between the nursing staff and the nephrologist, between the hospitalists and other specialists that are around at that hospital, with that either one or two of those nephrologists, whoever's rounding for that on that particular week. The average census, these are small hospitals. The average census could be anywhere between 2 to 5, sometimes just 3, sometimes less. And at times, during the COVID time, these census were high. We had about maybe 8 or 9 patients, but average in every hospital is usually less than 10.
Wow, okay. Another question is, looking back at the launch of the program, what challenges or pain points did you encounter along the way? For example, were there workflow gaps or change management concerns, technology hurdles, or other points where the process felt harder than it needed to be? And then understanding these experiences can help identify opportunities to strengthen future implementations.
Gosh, we've learned a lot. You know, telemedicine was new to me when I arrived at Globe, at Cobra Valley, and fairly new. I mean, we'd had telestroke. There were some pretty universal teleprograms that were out there. But when I started there, we didn't have a lot of telemedicine that was utilized. So, really understanding workflow, I think that's a great question. Staffing models, we probably changed the staffing model 4 times in the first year. You think something's going to work. I'd been a CNO for a lot of years in different rural hospitals, and so I had a bit of experience. But Dr. Sahani and I worked a lot on, policies and procedures, staffing, what's this going to look like? And there wasn't a lot else out there for us to compare to or to glean information from. So we just started and then we modified as we went. I tell all of our clients that we currently work with, we provide them a lot of tools. We have a toolkit of things such as staffing models, policies and procedures, order sets, documentation tools. These were all things that we developed from scratch when we started at Cobra Valley, things I wish I would have had. And that's one of the things I think Teleneph really shines, is that we're able to provide those resources to rural hospitals. Dr. Sahani and I know firsthand how busy people are, especially in rural hospitals. They wear a lot of different hats. And so if we're able to help them launch this really successfully high quality program, that's what we're there to do for them. And so lots of lessons learned. Technology never stands in the way, as our CEO always says, of us being able to care for patients. Our nephrologists have remote access to each facility's EMR, so they're able to document in the EMR, which is a real positive, I think. Some services have their own documentation. It doesn't integrate with the hospital EMR, so our physicians document directly into the EMR, so the team at the hospital has access to all of that information very timely. They put orders in the system, and I think what's changed the most since I've even been with Teleneph is actually the televisit portion. And Dr. Sahani, you talked a little bit about that, not needing the big technology anymore, just an iPad, the ability to actually visually see patients from a distance has gotten so much easier over the last several years.
That's great. Let's see here. So some of the pain points that maybe you experienced when you were setting it up in Globe, and they've been able to, of course, expand and move past some of those challenges. Any things that you do different to start?
Go ahead, Dr.
If I
Sahani.
could just add,
Yeah.
and this is what happened at Globe. Just by adding dialysis as a service, bringing on a nephrologist, they could open up other service lines. So soon
Sure.
after that, he added cardiology. He opened up a cath lab, and then they also were able to add orthopedic. I think, as Rhonda mentioned earlier, it just creates a halo effect because these patients, as we know, unfortunately, are high utilizers of healthcare. So if they had to go to see a cardiologist outside the community, then now they can because there's dialysis available in the hospital, even though if there was a specialist available in that community to start with. So what we've seen is just by, and, and, and many times we didn't have this expectation that it would grow the way it has grown. It would be adopted the way it has quite easily been adopted. And it's as you know, in rural communities, the whole community gets behind uh, uh, such a program. I also want to share one of our first nurses who we trained expanded her skill set. And when she left the community, now she's working as a dialysis nurse at an outpatient in-center dialysis facility. So she learned the skills where she was with us, said she wanted to move on, but she carried that experience and that learning, and now she's a dialysis nurse at an outpatient dialysis facility. So these are the other benefits of the program, which we never anticipated. And when the next time you have us on, we'll have more benefits, which we didn't anticipate.
Is some of the unplanned benefits, you're right, getting one specialist in, it became easier to bring some of those other specialists into those rural areas and those critical care hospitals. That's an amazing story, and could be a great example for some of our other, critical care hospitals and our rural hospitals. Just getting one in, well, then it opens up that opportunity to be able to bring in others. That's great. Any other questions for our presenters today? Go ahead and please put that in the chat. We do have an evaluation that will pop up when we're done. Any other comments? What would be interesting would be to have some of the folks from Globe maybe come in and be able to do a webinar and talk about their Teleneph and then some of the other specialties that they were able to bring in. It's really important in our rural communities, to make sure that those services are available and people can stay in their communities and get their healthcare needs. I don't see any more.
Absolutely. And I'm sure they would be willing to do that. They have seen the value. The CEO is a great speaker and very positive, obviously, about the program. And I mean, he and Dr. Sahani worked on making this happen for, I don't know, probably 10 years before I was even there, because, the value, and we've known telemedicine has been out there. I think, a vendor for a telemedicine company asked me not too long ago, why is it that it hasn't been integrated into healthcare as quickly as I think that people expected it to be? And it really is. I feel like you have to understand that it's a different workflow. And so you really have to focus, which again, we didn't know when we were doing it, but you can't take your typical workflow for patient care and try to just transport it onto a telemedicine type of service. You really have to walk through a different workflow. And we spend a lot of time with our clients talking about that. It takes most hospitals about 90 days to get this new service line up and running. Part of that is obviously getting the equipment in, the supplies, training, contracting, all of those things. Credentialing of providers usually takes about 90 days. So we get that process started very, very quickly. As Dr. Sahani mentioned, we assign just 2 providers to each facility. So they become part of the team. I think that is a real success to Teleneph, that's the model. Rural hospitals, they want to know who they're going to call. The nurses feel much more comfortable if they know they're going to pick up the phone and talk to Dr. Sahani, who they know and they've talked to many times before. And so that workflow and just making sure that all the steps are considered is really, really helpful, I think, in the success when you're bringing up a new service of any kind, let alone then adding the telemedicine piece to it.
We have another question that came in. What are the future plans for expanding the programs, and what are some of the major anticipated barriers to growth?
So I'll take the first half of that question. Thanks for asking that question, Kerry. We've got a really dynamic CEO, and sometimes I butcher his quotes, but I'm going to try this. He says, who we are today is not where we are tomorrow. I think I got it right this time. So we started off just being servicing small rural community hospitals, critical access hospitals, and we've seen the need or shift to integrated health systems as well, especially when they have their own integrated health system hospitals in smaller communities such as Intermountain up north, Life Point down south, and Oshner, and Deaconess in the Midwest. So they've approached us to help them out. And Deaconess may not necessarily be a smaller, maybe a bigger community hospital, but because of the absence of adequate nephrology coverage, they've asked us to come and help. So as we grow, that's where we see a potential opportunity to just either fill in the gap geographically or fill in the gap on the personal side of not having the ability to have more than one nephrologist on site. That's where we see our future plans of expanding. And basically, because we're tele, all of the country is available to us.
Sure.
Another group of patients that I don't think we had considered at all were a couple of them. One were the LTACs, long-term acute care rehab facilities. They certainly see the financial impact of being able to provide dialysis services themselves within their own 4 walls versus sending those patients out or contracting with another entity to come in and do dialysis for them. Often they talk about, dialysis or rehab patients have to have a certain amount of rehab hours a day. And with contracted services, they didn't have as much control over when the dialysis treatments would be completed. And then if there were acute nephrology issues with their patients, because some of these folks, take care of very high acuity LTAC patients, and then to have nephrology available for them as well. The other group that we're working with, 2 different groups actually, are the correctional facilities.
Yeah.
So this was fascinating to me. I have no experience with correctional facilities, haven't been in one and don't really plan on it. So learning from the folks at the correctional facilities, the cost for them to send a patient out to an outpatient dialysis center with a driver and 2 guards and, all the expense when they've been able to bring in-source this service with utilizing these home machines, utilizing their nursing staff that they already have, it has been a phenomenal benefit to that group of patients. So it seems like every few months, a new healthcare entity sort of comes out of the woodwork and reaches out, or we reach out to them, determining, what are their needs. So Dr. Sahani is exactly correct. Our CEO says it all the time. We continue to change, and I feel like we are incredibly mobile and flexible and have the ability to really listen to what the needs are and shape our services based on what people are needing, which makes it incredibly exciting.
You bring up the Department of Corrections. We had a webinar yesterday with Dr. Klotz and Dr. York. They actually facilitate the HIV clinics within the Arizona Department of Corrections. And they talked about their experience with incarcerated patients and how tele is a great way to be able to bring, all of those specialty healthcare needs to that population that wouldn't necessarily have the ease access. Yes, we'll have some contact information we'll send out in the thank you email. That we'll get that available for everybody. Any more questions? The last question of the other question was the anticipated barriers to growth.
I don't anticipate any. I don't know, Dr.
Okay.
Sahani. I
think
feel
Rhonda-
like we try to anticipate, but go ahead, Dr. Sahani. What are your thoughts?
I think you already said it in part of your comments, is that we will customize it to any perceived barriers that the site may have, right? I think so. We listen to we have a template, but it's a flexible template. It's not it's not rigid. So when we start a program, we listen. The first thing we do is to listen what their needs are, what the community wants are, who do they have on staff, who do they need to bring on staff, and then we'll make a tailor-made solution. But knowing that the crux of it all is having that excellent service. We often say response time from a nephrologist is within 10 minutes, and we'll hold you. You can hold us to it, right? So it's service driven till that confidence between the nephrologist and the nurse, I want to say, is maintained, and then it's just smooth flowing after that. And that particularly takes about not long, maybe 6 to 8 weeks at most, because the nurses are on shift rotation, the nephrologists are just 2. Once that confidence build up, then we've seen it just take off.
Gotcha. All right. Any other questions for our presenters today? Thank you for those that have posed some questions for them to answer. We've got some great responses. And I'm learning about this as well. I met the CEO in a conference this last summer and was very interested in telenephrology because we haven't had a talk on this before. So I appreciate you folks being able to put this together for us today, and look forward to speaking with you, Rhonda, especially with your contacts back up at Globe. I think that would be a very interesting webinar to have on what those critical hospitals are doing and how they are taking care of other rural areas that are, with the patients being transferred in and not just being transferred out. I think that's a great.
Yeah.
So with that, otherwise we've got just a few minutes left. Any closing remarks for today?
When you see our CEO, tell him we did a good job.
And thank you so much, Melanie, for inviting us.
Yeah.
We absolutely love to talk about it. It's amazing work, and very very rewarding.
Just like the title of your presentation, keeping the care local, telenephrology. We've got all sorts of other, healthcare disciplines trying to keep that care local so that people can stay in their communities and get the healthcare that they need. All right, so with that, we're going to go ahead and end, and everybody, you'll get about 10 minutes back to your day. So thank you again for joining us. Please check our website. I will be sending out a thank you email to everybody with the information and the links, and we look forward to seeing you at a future webinar. Thank you, everybody.
Thank you all.